Depending on your time zone, good morning, good afternoon, or good evening. Welcome to the American Thoracic Society and European Respiratory Society joint webinar on global perspectives on COVID-19. My name is Juan Carlos Celedon. I'm President-elect of the American Thoracic Society, ATS. I'm the Niels Jern Professor of Pediatrics and Medicine at the University of Pittsburgh and Division Chief of Pediatric Pulmonary Medicine at the University of Pittsburgh and UPMC Children's of Pittsburgh. I'm joined in this webinar by my co-moderator, Dr. Eva Polverino. Dr. Polverino is President-elect of the Respiratory Infections Assembly of the ERS and a pulmonologist at Vall d'Hebron Hospital in Barcelona, Spain. I would like to thank the ERS for their collaboration tonight on this webinar, as well as our distinguished international panel of speakers for providing their insights into the current COVID-19 pandemic. The aim of this webinar, which is part of a global health series, is to allow respiratory health professionals in different regions to share their experiences with COVID-19 so far, and to have an opportunity to ask colleagues in other regions questions. This webinar will include practitioners and professors from France, Italy, Germany, and New York. With that, I'd like to introduce our first speaker, Dr. Marc Humbert. Dr. Humbert is the Vice President of the ERS. He's a Professor of Respiratory Medicine at the Université Paris-Saclay in Le Kremlin-Bicêtre in France. He is the Director of the Department of Respiratory and Intensive Care Medicine at the French Pulmonary Hypertension Reference Center and Severe Asthma Clinic at the Hôpital Bicêtre, Assistance Public Hôpital de Paris in France. Dr. Humbert.
Thank you very much to the ERS and ATS for putting together this webinar. I think it's extremely important to share our expertise and our experience in the setting of this major COVID-19 disaster. So today I will speak on behalf of my group, and I would like to thank all of them very warmly. And they have been outstanding during this crisis, and they are still on board working night and day on COVID patients in the ICU and in the department. I have, next slide, please. I have nothing to disclose regarding this presentation, except the fact that I'm the Vice President of the European Respiratory Society. And as you can see on the picture in the bottom of the slide, please stay at home if you can. If you are not involved in the healthcare crisis, you really have to stay at home in order to lower the risk of major pandemics in your countries. Next slide. I will describe very briefly today the COVID-19 pandemics in France and in the Great Paris region since March 1st, so in my region. I will also briefly present some challenges we faced when treating patients with the COVID-19, and I will give you some recommendations, practical tips or strategies which have been useful in my department, in my experience. As you can see at the bottom of my slide, there are some drawings from the kids of my colleagues and nurses, and I just want to thank all the families who have been behind us during this crisis. Next slide. So this is a map of France, and you can see the clusters of COVID-19 in the recent weeks since March 1st. You can see that there were at least 3 major clusters, one very big around Paris, and the Great Paris region is 12 million inhabitants, and we had many cases. I'm going to show you that in a minute. One in the east part of France, in around Strasbourg and Mulhouse, and one in the north of France. And you can see that there are other smaller clusters, but currently the threat has been very big in 3 major areas. In the Great Paris region, I repeat, 12 million people, we had more than 13,000 hospitalizations currently. And this is a huge pressure on the health system. Next slide, the bigger threat is the critical care. And currently, we have more than 2,600 patients with COVID-19 hospitalized in critical care departments in the Great Paris region. And something very important is that this number of beds was not ready when the crisis started. We had to multiply by more than 3 the number of beds available in order to respond to the crisis. Very fortunately, we were not overwhelmed. So thanks to this increase in beds, we were able to take care of all critical care patients. But it was very, very close to an overwhelming situation. And if we have a second wave, we have to be aware that we may not be able to take care of all patients, and we don't want that. Then the next slide, as we can see now, is the hospital deaths in the Great Paris region. And you can see that in hospital deaths were more than 3,500 between 1st of March and mid-April. On the next slide, you can see how the epidemics developed. It was very sharp. We always give the results from 1st of March, but on 1st of March, there was no problem at all in terms of hospital capacity. And you see that it's around the 15th, 20th of March that the number of hospitalizations increased. And as you can see with the blue line, it was very sharp after 20th of March. And this is really the threat we all face, is to have like a tsunami of cases coming within days and overwhelming all the ER departments and all the critical care and pneumology departments. So on the next slide, you can see critical care. And critical care is even more challenging because in our region, we could not welcome on a regular basis more than 800 patients. And you can see that within days, the number of admission has been over 2,500. So there was a need to very quickly, very fast, adapting the capacities of our ICU and find space, find staff, and find expertise. And this has been possible. And I'm going to show you next slide some challenges and recommendations I can make. So the first thing I can discuss now is the organization. You need to be ready, and you need to be ready now. The team should be able to adapt within hours to a completely different situation. And clearly, I want to thank very warmly Stefano Nava, Sergio Harari, and many colleagues from Northern Italy who told us that the threat was coming. And my colleagues also in the east part of France who were exposed earlier than us warned us. So we need to have a discussion with our colleagues and be aware that the threat is coming. In response to that threat, in my own department, overnight on a Saturday evening, on 14th of March, we emptied completely one wing of the department in order to admit COVID-19 patients. And during that period, we also emptied the rest of the department, which became COVID only within a couple of days. You may know I'm a specialist of pulmonary hypertension, but all my patients with pulmonary hypertension were advised to go back home or to be treated in another place in order not to be exposed to this COVID-19 threat and in order to allow us to take care of the very important number of patients who came. We also had to secure as many ICU beds as possible. We multiplied by 3 the numbers of ICU beds, and this was important. We also closed the research labs, which are not involved in COVID-19 research, and we hired all the MDs, all the residents from the labs in the department, as well as technicians, engineers, and staff in order to help us. The second big story, and I'm sure Stefano will mention that also, is to protect yourself, protect your colleagues, protect your staff, protect your family, and protect your patients. And there was a shortage of everything at the beginning, and we had to use carefully the masks, the protections, but we need to be trained, and you need also to stop the visits from outside for the patients. And we need, for that reason, also a lot of psychological support for the patient and staff. A substantial number of healthcare providers will be sick despite protections. And you need to know that, and you need to increase the number of people in the department in order to be ready to substitute people who will be unwell during a period. We need volunteers. And you have to protect the non-COVID patients, acute and chronic diseases, with non-COVID areas in the hospital, externalization of non-COVID care as much as possible, and provide internet or telephone-based clinics and follow-up. Next slide. I would like also to give you some recommendations about how to welcome the patients with COVID in your hospital. We had a huge number, hundreds of patients coming within days with COVID-19. You need to triage the patient, and there is a major role of chest imaging. CT is better than chest X-ray, but you have to do with what you have. We prioritize CT to identify COVID-19 pneumonia. PCR is interesting, but you have problems of delays. We don't have point of care test yet. And false negative. You have quite a lot of patients with COVID-19 who will test negative. So you have to know that. And the CT scan can correct this false diagnosis. Care, hospitalization in COVID plus areas with dedicated teams, and you need to train your team. Oxygen should be, of course, available everywhere. Anticoagulation is extremely important. We are very impressed by the number of pulmonary embolism and deep vein thrombosis in that setting. In terms of treatments, we don't know what is efficacious for COVID-19 itself. And there is a lot of media pressure for unapproved therapies to be used. And our response to that was to prioritize randomized controlled trials rather than giving treatments which are not proven as efficacious. And ICU, my colleagues will discuss it, but ICU should be very important in your hospital, and you should increase its capacity. Among the complications within days after hospitalization, you need to know that venous thromboembolic disease is very common, and that COVID is often a systemic disease with heart, kidney, liver involvement, etc. Research, I did mention it a few minutes ago, research is prominent. You need to establish cohorts of patients treated with standard of care and sometimes investigational agents. And we have CORIMUNO, which is a randomized control cohort, which is very useful to test the immune therapies like anti-IL-6. Randomized trials like the European Trial Discovery will allow to test at the European level several drugs, including hydroxychloroquine, which are currently promoted by some without strong evidence. There are other research programs which can be also discussed. Next slide, my conclusion will be very soon, but I will want to insist again on the CT scan prominent role for triaging. And when you are with a moderate to severe patient, when you are faced to a moderate to severe patient with high test probability, imaging can be very important to triage your patients. Next slide shows you the conclusion. You need to be aware, you need to be ready for action, you need to prepare your team, you need to protect yourself and the patients and the staff and the family. Triage, PCR, but chest imaging is prominent. Collaborative research will be important. Many complications of your patients will have to be considered, including venous thromboembolic disease, and you have to manage your COVID plus and non-COVID patient in your hospital, and you have to organize yourself. My final slide is a thank you slide. I would like to thank you very much, and I hope that we will be able all together to resist and fight and win against this COVID-19 disaster. Thank you very much.
Dr. Humbert, thanks so much for your excellent presentation. So Dr. Humbert, I have two questions from the audience. The first question is, what is the role of low molecular weight heparin and generally anticoagulation in the treatment of patients with respiratory failure due to COVID-19?
The role of anticoagulation in the COVID-19 epidemics is extremely important. In my country, the first patients who died of COVID-19 died, in fact, of massive pulmonary embolism. And now, on a regular basis in my department and in France, we have seen a lot of patients with venous thromboembolic disease. So what we do right now, we advocate for the treatment of patients with COVID-19 with anticoagulation. And we have put this together, this algorithm of anticoagulation, in which we analyze the different risk factors for venous thromboembolic disease, including BMI above 30, history of thrombosis, risk factor for thrombosis, the level of D-dimers above 3,000, of fibrinogen above 8 grams, and we have also the different COVID-19 situation, whether the people are doing fine on room air, whether they need oxygen, or whether they need high flow oxygen or ventilation. Depending on this, we have different levels of anticoagulation, ranging from prevention to curative treatment. Really, we advise for at least prevention for all patients. And as soon as you need oxygen or ICU treatment, we really consider curative treatment as early as possible. And in my department, we promote low molecular weight heparin if the renal function is according to the current recommendations.
The second question is, do you think that asthmatics represent a category of people at risk for COVID-19 infection? Do you believe that asthmatics should stop inhaled steroid therapy during this pandemic?
Well, asthma is a very important disease, and obviously patients with asthma are very concerned with the COVID-19 epidemics. We believe right now, after a few weeks and months of epidemics, that asthmatics are not at higher risk of COVID-19, and they do not develop a severe condition related to COVID-19. So currently, what we recommend is to maintain the treatment of asthma. The biggest problem would be to stop it. So we should maintain the treatment of asthma, including inhaled corticosteroids and other therapies. When you have an exacerbation of asthma, you have to treat it as usual, and you can use oral corticosteroids as you are used to do. And last but not least, the most severe asthmatics, they can maintain their biotherapies.
Thank you, Dr. Humbert, very much for your nice presentation. And it is time now to introduce our next speaker, who will provide a perspective from Italy, Dr. Stefano Nava. Dr. Stefano Nava is a full professor of respiratory and critical care at the University of Bologna, Italy, and I have to say is one of the leaders of the Italian School of Pulmonologists and Intensivists with high expertise in ventilation. Please, Stefano.
Okay, I have no conflict of interest for this presentation. And first of all, I would like once more to thank the ATS and the ERS for this important opportunity, I think. I share 1000% what Professor Hubert said so far, and I will expand a little bit some particular aspect of my country. But first of all, as Mark Hubert did, I want to thank all my colleagues. I want to thank all the nurses. I want to thank all the respiratory therapists and technicians. And why not also our families that were supported us a lot in this, what we call apocalypse now time. I think we also learned a lot from this virus. The first thing is that we realized that most of us were acting as individuals. While when you face a pandemic, you need to switch your mind and act mainly as a team. You need to row at the same part. You don't need to individualize the treatment, but you always need to be part of a team. The second thing that we realize is that as a clinician, we used to have this approach that is obvious, correct in the large majority of patients, that is self-centered, is centered to the patient. This is fine, but when pandemics occur, you need to expand your interest outside the hospital, and therefore you need to face something that eats not only the hospital, but also the community around the hospital. Next slide. Well, everything started around 3 weeks before what happened in Paris. And it was February 21st. Everything happened in Codogno, that is a small city relatively close to Milan. In Italy, we got around 4 different clusters. The largest one is in Lombardia, that is where Milano is the capital. Then on the east part, you have Veneto. On the left-hand side, you see the third cluster, that is Piedmont or Piemonte. And last but not least, you have the fourth cluster where I live actually, that is Emilia-Romagna, and Bologna is the capital. Up to 2 days ago, we have 156,000 who tested positive, and we reached yesterday 20,000 deaths in all the country. Next slide. Well, before starting to talk about the specificity of this disease in my country, I want you to get an overall picture of the number of critical care beds normalized per 100,000 people. Well, from this slide, it is absolutely clear that Germany has the largest percentage number of critical care beds compared to the other European countries. Italy and France are relatively close, since France has 11.6 and Italy have 12.5 critical care bed over 100,000 inhabitants. Other countries like Spain, Portugal, and Greece, unfortunately, they have a very small numbers of critical care beds. And this, as Mark already said, is extremely important when you face a pandemic. Next slide. Well, you should also consider what it is called hospital capacity. Hospital capacity, as you can see in this slide, is the number of cases per critical care bed in each country. And once more, you saw that here, Spain and Italy are at the top of this ranking. That means that in each bed, we treat 8.5 for Italy and 7.8 patients in Spain. And you see that Germany, since it has the largest number of critical care beds in Europe, is in a much better position. One bed is only for 1.2 patients with coronavirus. Next slide. Another way to see the problem, the epidemiological problem in the hospital, is the number of coronavirus cases per 1,000 hospital beds in each country. Well, once more, you see we face a terrible burden. 332 patients out of 1,000 beds were occupied by patients with coronavirus. In Spain, 250. France did at least up to a certain point much better than we did in Spain and Italy. And once more, Germany was still in a better position. Next. Well, this is the European situation concerning the critical care bed. And I want to present here one of the few published studies in Europe so far, that is the critical care experience in Lombardia. These data refer to less than 4 weeks, from February 21st till March 18. And here is this experience of the large 10 million inhabitants region in Italy. You can see that the mortality rate was in line with what reported already, also in China, excluding the first few studies, with 24% mortality rate. Most of these patients were affected by severe comorbidities like cardiovascular disorders, COPD, malignancies, diabetes, and hypertension. Well, interestingly enough, all the patients in the ICU received mechanical ventilation, and only 12% of these patients were ventilated non-invasively. But this may be important for pulmonologists. Next slide. Well, the problem is that in these 3.5 weeks, we admit in Lombardia, as I said before, 1,591 patients. But we admit to the hospital almost 9,000 patients. So this means that these 9,000 patients were admitted mainly with acute respiratory failure. So what does happen to the difference between the 9,000 patients admitted to the hospital and the 1,500 admitted to the ICU? Next slide. So we face something that it was totally unexpected. We need to treat patients with acute respiratory failure outside a protected environment like ICU or respiratory intensive care unit. So we got a very early consensus management for non-ICU acute respiratory failure patients. And we published this recently over ERJ with a title, From Ward to Trenches, because this is what really happened in our country. Next slide. Here we developed a sort of flow chart. It was a sort of triage for our patient. I don't want to go into detail. If you want to, can read the paper, but I want to stress only a couple of things here. You need to be very fast in the triage, and you need to understand very quickly if this patient may be discharged at home, if he requires hospital admission, and which level of expertise does she or he needs. And once more, you need to do very fast. As you see here, we wait 30 minutes in the first evaluation and 2 hours after the patient was eventually placed on mechanical ventilation, like CPAP or non-invasive ventilation, or even high flow or standard oxygen therapy. After 2 hours, you need to reevaluate the patient and find the safest location for the patient. Next slide. To assess the patient, we were not basing only on arterial blood gases. Sometimes it's difficult to perform arterial blood gases when hundreds of patients are coming to the emergency room. So we use what we call the NEWS scoring system, that is a very simple and easy to perform score to assess the severity of a patient, and most important, the change in the severity of a patient in a small time interval. Next slide. Well, here I show you some rough number of what happened to the patient not admitted to the ICU. About 10% of the patient received standard oxygen, about 20 high flow oxygen, either with a reservoir mask or Venturi mask, about 20% high flow nasal cannula, that is, as you know, is a different system of providing oxygen. 30% they receive CPAP, mostly with the helmet, because of easy of use and safety issue. And around 20% were receiving non-invasive mechanical ventilation. All these patients were treated mostly outside a protected environment. So at one point in time, we did not care about negative pressure chamber because we need to take care of the patient. Next slide. With time, we learn a few things. We learn, as in this example, that you can prone the patient even using non-invasive mechanical ventilation, and not only when the patient is intubated. On the left-hand side, you see the patient in the supine position, and in the right-hand side, the same patient less than 1 hour later in the prone position. Next slide. Here are the arterial blood gases, just to show you very briefly that the patient in the supine position during NIV has a PaO2 of around 73 millimeters of mercury. As soon as we prone the patient with the same setting, we could gain about 40 millimeters of mercury of PaO2. And if we put the patient in a Trendelenburg position, we could gain more delta in PaO2 level. Next slide. Well, these are the couple of last slides. And first of all, we were totally under pressure as a clinician, as I said, nurses and doctors, clinicians, and people outside the hospital really understand what we are doing. This is a banner outside the Crema Hospital. Crema Hospital is my hometown. And here they say in Italian, medici e infermieri siete il nostro orgoglio, grazie. That means doctors and nurses, you are our pride. Thank you so much. Next slide. But I think, as Mark Hubert said, one of the most important things for the clinician is to protect themselves. As a fast track, we published recently this sort of practical indication how to protect yourself during a COVID-19 infection. We were not ready, to be honest, at the beginning. So we faced a disaster, and next slide, and the disaster has a name, death. This talk, and I finish with this slide, is deeply dedicated to my friend Giuseppe. Giuseppe was a pulmonologist Como, lost in action on March 9, 2012. And I want to dedicate it not only to Giuseppe, but all the other 114 doctors and 34 nurses, they died of COVID infection on duty in my country. And once more, I thank you and the ATS and the ERS for this opportunity, even to remember these colleagues.
Dr. Nava, I have a specific question for you regarding the role of non-invasive ventilation in the management of respiratory failure due to this infection. Is there any risk of delaying intubation in these patients?
Well, as I show in one of my slides, when you face acute respiratory failure and ICU bed are running out, so you need to start treating patient non-invasively. So I know that in ideal world, people are very concerned about the aerosol problems during NIV, and this is right. However, when you need to treat a patient, and as I said, you don't have negative pressure room, you do not have ICU beds, you need to do everything with what you have. So NIV was largely used in my country, and I would say that roughly the success rate was around 50–55%. And when I say NIV, I do not only refer to BiPAP ventilation, but I also refer to CPAP. That is not a real mode of ventilation, but I found CPAP very useful for the ease of use outside a protected environment.
Dr. Nava, given shortage of PPE in some areas, many people ask whether you have ways to reuse this material and guidelines regarding it.
Well, yes, we have guidelines. We have guidelines that are mostly based on the World Health Organization, and they are, you can find it easily on the paper that we recently published on the European Respiratory Review. We do not have a protocol for reuse this device, because the issue is very controversial. It depends which device are you talking about. Even the mask may be totally different according to where they are built and which kind of mask are you using. One more thing about protection. I was talking before about negative pressure chambers or rooms when you use high flow oxygen or NIV. Well, if you do not have negative pressure rooms, you can still use high flow and non-invasive ventilation and CPAP, also according to the World Health Organization. You need at least an air recharge of 160 liters for an hour. And you can easily obtain this opening the windows and the doors. So don't be stuck with the concept of negative pressure chamber and ICU beds. You can easily ventilate it, I would say rather safely, your patient non-invasively outside negative pressure rooms.
It is my pleasure to introduce Dr. Charles Powell. Dr. Powell is a professor of medicine and system division chief for pulmonary critical care and sleep medicine at the Icahn School of Medicine at Mount Sinai in New York. He is also the CEO of the Mount Sinai National Jewish Health Respiratory Institute. Dr. Powell.
Well, thank you very much for the opportunity to share with you our journey in preparing for and responding to the COVID-19 pandemic in New York City. I'm coming to you from the Mount Sinai Health System, which is a large healthcare system in New York with hospitals in all boroughs of Manhattan and in Long Island, with a baseline capacity of 2,500 beds. Next slide, please. What I want to cover for us today in this journey is to take you through the perspectives that we had as we prepared for and encountered the surge. Really, initially, in terms of the preparation, the main problem was one of volume. And by that, I mean preparing to be able to meet the needs for all the patients who potentially would enter our health system with COVID-19, and understanding that the potential peak in terms of hospitalizations could outstrip the supply of beds, equipment, and personnel that were available at our health system, not to mention other health systems in New York. That's a volume problem. I'll talk to you then in terms of how we tried to mitigate these potential constraints in terms of supplies with regards to equipment and beds, with regards to personnel and how we prepared personnel. And then as we were able to meet the demand, we'll focus our attention on the disease itself, the lessons that we've learned from our experience and from the experience of our colleagues in Europe and in China about the unique aspects and the heterogeneous aspects of disease pathophysiology and what our response has been to these learnings. And then if there's time, I hope we can discuss what normal will look like once we get past the peak and get past the mitigation steps of COVID-19. Now, when I talk about the volume problem, back on the prior slide, on the right-hand side, I show you the projections from the modeling that has been done every day in the Mount Sinai Health System to project the number of hospitalized patients in our health system on any particular day. The model is based upon the algorithm developed at the University of Pennsylvania, the CHIME model algorithm, that takes into account the prevalence of infection within the community, the population of the community, the market share of the health system, which is 13% as it relates to the Mount Sinai Health System, the length of stay for patients, and the impact of social distancing. When the modeling first was performed in Manhattan for the Mount Sinai Health System in March, when we're starting to see cases come into our health system, the projected peak number of patients hospitalized in our system was estimated to be over 20,000. That's a big problem because, as I mentioned up front, the Mount Sinai Health System only has 2,500 beds. Like every other health system in New York, we were requested by the Department of Health to increase our capacity, which we did to 4,200 beds, but that still was not going to be sufficient to meet the peak that might occur in the absence of any social distancing. New York went into a mitigation strategy approach with closure of schools and enforcement of social distancing practices in the middle of March. And every day after institution of these social distancing practices, the models showed that the peak number of hospitalized patients would decrease by anywhere between 1,000 and 3,000 per day. And we'll show you what this looks like in terms of the number of patients hospitalized in our system. So, next slide, please. Here on the bottom, I'm showing you data from the New York City Department of Health, which records the number of new hospitalizations on every day since March all the way through the beginning of April. What you can see is that early on in the beginning of March, it was just a few number of patients. And this is when the state of Washington was dealing with their pandemic. But then it picks up, and it picks up fast, such that by March 31st and April 3rd, we're reaching very high numbers of patients presenting every day to all the emergency rooms throughout the entire city of New York and all the boroughs, and overwhelming the emergency rooms and the inpatient facilities and the critical care units of all the hospitals, despite preparations to be able to meet the surge. At our peak, we had 1,962 COVID positive patients in our health system. 452 were in the ICUs. Next slide. Now, there were a lot of lessons that were being learned as we were dealing with this pandemic. Some of the lessons had to do with the types of risk factors that were important in terms of risk for having the disease and risk for having a more severe versus a less severe course of the disease. On the left-hand side, I'm showing you data as it pertains to the impact of age and gender on the number of cases that are seen. And what you can see is that when we start looking at individuals between the ages of 45 and 75, there's not a lot of difference in terms of the number of cases that present with COVID. But there is a significant difference associated with advanced age when we look at the number of patients who are hospitalized. So fewer patients between 45 and 64 are hospitalized compared to those who are 65 or 75 and older. We see a similar impact as it pertains to gender. So in terms of cases, there's a small increase in men compared to women in terms of presentation with the diagnosis of COVID-19, but there's a much bigger difference in terms of male versus female hospitalizations for COVID, with men being at more risk of presenting to the hospital than women. So when we put this New York City together with our own data from Mount Sinai, where we have looked at the epidemiological characteristics of patients, what we've noticed is that the epidemiological risk factors for severity of disease, and in our case measured by the requirement for ICU hospitalization or ventilation, the risk factors that emerge are advanced age, male gender, obesity, and diabetes, with also a signal becoming apparent for hypertension. Almost analogous to the metabolic syndrome phenotype in men here compared to women as being associated with the potential risk of increased severity of the disease. Next slide. So I mentioned up front that the problem in terms of preparations was one of volume. How are we going to meet the demand if indeed the demand is close to what is being projected by the modeling, and if social distancing doesn't decrease the peak and spread it out as we all hope and expect it might? So these preparations took place in several different entities. One was making sure that we had sufficient bed capacity. So we scaled up our beds in the health system from 2,500 to 4,200. We put beds everywhere. We have tents in Central Park. We have beds in the lobbies of our hospitals. We converted our recovery areas to ICUs such that we increased our ICU capacity from a baseline of 94 ICU beds at Mount Sinai Hospital to 240 ICU beds. We did that by making double occupancy the norm in our intensive care units as well. So that's how we tried to increase the capacity in terms of hospital beds. The other constraint that we were concerned about was ventilator capacity. For several months since January, we were working to source ventilators from anywhere we could purchase them from, domestic and foreign sources. And so we were able to increase our inventory of ventilators from 700 to over 1,500, with orders placed to bring in another 400 to get us to where we thought would be an okay point to be, which would be 2,000 ventilators. We also, at the same time, appreciated that if the worst projected peak were to happen at Mount Sinai Hospital, then 2,000 ventilators may not be sufficient either. So then we undertook alternative approaches to increase the supply of ventilators. Around that time, we received a donation from the Tesla Corporation, who donated to Mount Sinai and to several other health systems a large supply of home BiPAP devices. The question we had was whether we could use these home BiPAP devices to deliver invasive ventilation to patients in the ICU who were being ventilated through an endotracheal tube. So we put that question to our sleep research physiology team, which is world-class, and they came back with the answer, yes, we can do that. And they came back the next day with a protocol on how to do that with the circuit that I'm showing you below here, where we have the ResMed VPAP ST device as an example of a home BiPAP ventilator that can fit in the palm of your hand, that is quite powerful, and connected to circuitry that is typically available in any respiratory therapy department that incorporates HEPA filters to protect against expiration of the virus, that incorporates spirometers so that the tidal volumes and pressures in FiO2 and end-tidal CO2 can be recorded on monitors such as the one on the bottom left. We were able to add functionality such that the monitoring and remote control of the ventilator could be done from outside of the patient room so as to limit healthcare worker exposure to this ventilator. We trialed it initially and modified it using the simulation lab that is run by our anesthesia department, made modifications to the order of the spirometer and the oxygen bleed-in based upon the results of the spirometry, and then we're able to test it in the clinical setting as well. We anticipated that the optimal clinical setting for use of this repurposed home device would be best served in patients after they were initially stabilized on a conventional ventilator when they were first intubated for acute respiratory failure. Why? Because while these home devices are powerful, they're not as powerful as a conventional ventilator. Can't reach the inspiratory pressure levels that a conventional ventilator can and might be required by a patient, and cannot reliably achieve FiO2s of 100% that might also be necessary for a patient acutely intubated. So the strategy was to use this as a second ventilator for a patient once they're stabilized on a conventional ventilator, swap it out, if you will, in the case of a shortage, and then have that conventional ventilator available for the next patient who needed acute intubation. Next slide, please. We place as much attention to staffing as we did on equipment. So we onboarded about 350 providers to our health system within a period of a week. We sourced them from multiple different agencies and locations from around the country and brought them into the healthcare system. We provided them with training about how to be an intensivist or how to work in an intensive care unit if they didn't have recent experience in the intensive care unit. We provided them with training in how to don and doff PPE, and we provided everybody with PPE. And then we put everybody in a position where they could deliver appropriate care to patients who had COVID-19 associated lung disease. We're able to stretch out our healthcare provider resources by adopting the Society for Critical Care Medicine's tiered structure approach for the Mount Sinai Health System. And this was done expertly by the director of our Institute for Critical Care Medicine, Dr. Kohli Sethi. Here's an example of a staffing model that is employed by one of our ICU units, whereby you have a relatively small number of intensivists who then each oversee a large number of patients who are then staffed by hospitalists or other providers that are not board certified intensivists. This is just an example of one model that we used. We had other models where we had one intensivist in charge of 50 patients at a time in this tiered model structure. So it was a combination of training and placing a structure that allowed us to stretch the model so we were able to quickly have sufficient staffing to meet the demand. Next slide. So at the same time, we're paying careful attention to the patients who are presenting with severe respiratory failure associated with COVID-19. And it became clear to us, just as it was clear to our colleagues in China and in Europe, that this is not your typical conventional run-of-the-mill ARDS. It's more complex, it's more heterogeneous. The physiology doesn't fit. Initially, patients with respiratory failure have compliant lungs. That is not the norm in terms of ARDS. And so it became incumbent upon all of us to better understand the pathophysiology of this process so we can better direct our therapeutic approaches beyond the therapeutic approaches that we know are useful in acute respiratory failure, with the primary goal being lung protective strategies, which we all adopted very quickly. And in addition, we used proning, which showed some benefits in terms of improving gas exchange. What we observed is that our overall mortality in the ICU setting seems to hover around 25%. Number of patients we can extubate hovers around 25%. And the number of patients who require chronic mechanical ventilation hovers around 50%. But these data are evolving, they're not mature, and they will change as the experience accumulates and the denominator matures. In terms of treatment approaches, we use a combination of empirical approaches and multiple different clinical trials of multiple different therapies, all allocated in a judicious fashion so that we can offer what we think is the best treatment option to the most appropriate patient. I don't want to spend much time talking about hydroxychloroquine. I will just say that all admitted patients are offered, in some cases, hydroxychloroquine, acknowledging that the evidence base in support of this therapy is not very robust, and acknowledging that we do not administer hydroxychloroquine to any patient who has an abnormal EKG. We do anecdotally see some patients improve on it. Whether it's due to the drug or with the drug is unclear. We also use steroids and/or tocilizumab in patients who seem to be at high risk. And patients who seem to be in high risk are those who are in hospital day 8 to 12 and haven't gotten better, and especially those who have markers suggestive of an exuberant inflammatory response, typically associated with an elevated D-dimer and with an elevated C-reactive protein and/or ferritin level. We have multiple clinical trials in place. We have a large clinical trials oversight infrastructure whereby we vet every single drug or every single device that has been proposed as potentially being useful for study in the COVID-19 pandemic. Every day we are evaluating multiple candidates using expert panels to do the first review and passing on their findings to an oversight committee, which will then determine whether or not the drug or device will be moved forward into the clinical research setting. Thus far, several drugs have passed by and through that approval process. So we have ongoing clinical trials, both in the uncontrolled and in the randomized control setting for remdesivir, for IL-6 blockade with sarilumab. We have an active program using allogeneic mesenchymal stem cells. We have a very active program where at least 60 patients thus far have been administered convalescent plasma. This week we started a new trial for GM-CSF, and next week we begin an expanded access protocol for eculizumab, the complement inhibitor. We've instituted protocols to more widely institute a program that includes anticoagulation for individuals who appear to be at high risk for developing thromboses, whether they be gross large vessel thromboses, DVT and PE, or small endothelial thromboses that we see as a potential pathophysiological mechanism. And we use a similar risk factors for determining individuals at high risk paying close attention to avoid anticoagulation in individuals who would be at higher risk for bleed. Next slide, please. Here's just an example on the left-hand side of our anticoagulation algorithm that is in place at the Mount Sinai Hospital. And on the right-hand side is an example of some of the learnings that we've made in terms of some of the unique presentations in terms of the pathophysiology of this disease in patients. We had a series of 5 patients presenting all on the same weekend with progressive critical care illness, whose blood gases all showed a severe dead space ventilation defect associated with shock. It really appeared as if there was an endothelial thrombotic process potentially also associated with concomitant endothelial dysfunction and vasodilatation in these patients. The physiology also was reminiscent of the physiology that's seen in patients with massive pulmonary embolism. So as a therapeutic option that was employed in these patients with progressive severe critical illness who were near death, these patients were administered TPA with concomitant heparin. The physiological response was quick, and it showed a quick decrease in the PCO2s and increase in the PO2s and an improvement in the hemodynamics and reduction in pressure requirements for many of these patients, suggesting that in terms of pathophysiology, there may be a role for endothelial thromboses. This has been followed up now with modification of this protocol in a off-label use where patients who have similar physiology presentations who provide consent are now administered not TPA, but now tenecteplase with antiplatelet agents. And that experience is accumulating in the research setting at the Mount Sinai Hospital right now. Next slide, please. So that concludes some of the aspects of our journey thus far with regards to preparing for the pandemic, with regards to our response to the pandemic, with regards to the learnings that we and others have made about the unique pathophysiological aspects of COVID-19 and our response. We have now passed our peak. We hit the peak on April 11. We still have many, many patients with significant and severe COVID-19 lung disease. We look forward to additional learnings that will come from the academic community. We look forward to the results of clinical trials that are being performed at our institution and others that will better inform us as to the most appropriate therapeutic options we have available for our patients. And we look forward to the continued efforts to mitigate against this disease with social distancing so that we can further reduce the onset of new cases and hospitalizations and get to the point where we can be in a new normal environment and move past this as soon as it's feasible. Thank you very much for your attention.
Dr. Powell, there were 2 questions from the audience. The first question is, what is your position on early versus delayed intubation in patients with COVID-19 and high oxygen requirements? Should prone position or other measures be used in patients with COVID-19 who have high oxygen requirements but are not on mechanical ventilation?
So the first question has to do with whether we have a preference for early versus late intubation for patients with respiratory failure and COVID-19. Early on, I think there was a perception that early intubation might be an advantageous strategy to employ for patients with COVID-19 respiratory failure. That has not been our practice. Our practice is that we try everything that we can to safely support patients with supplemental oxygen if they have hypoxemic respiratory failure. For that, we use high flow. For that, we use 100% non-rebreather mask, and sometimes in combination, because we have had patients who have demonstrated recovery if they had sufficient time to be supported without being intubated. We thus save intubation for those who continue to progress despite high flow nasal cannula oxygen with high FiO2s and high flows, and despite 100% non-rebreather. The next question had to do with whether or not we prone patients even before they are intubated. And the answer to that is yes. And so we have a protocol for self-proning, in essence, having the patient to lie on their stomach for greater than half of the time that they're in bed. It is associated with improved gas exchange. And so we use that whenever it's feasible. It's a nursing-driven protocol with attention being paid to the position of EKG leads and avoiding pressure points and such. It's very safe and it is effective.
The second question to you is, it is challenging sometimes to wean patients with COVID-19 from mechanical ventilation. Does an echocardiogram have any value in guiding the weaning process, as it seems to be useful in predicting whom will be responsive to pronation? Thanks.
So that's a very good question. Our experience is similar in that the prevalence of chronic respiratory failure is higher than what we are commonly used to in the ICU setting. It may be up to 50%. We don't use transthoracic echocardiography in a routine fashion. The information provided by the echo doesn't typically drive our therapeutic approach and doesn't typically provide enough prognostic information to justify the risk of exposing a provider to the close contact that's required to do the echocardiogram for patients.
Thank you, Dr. Powell, for your nice presentation and overview from US. And it is time now to introduce our next speaker, Dr. Tobias Welter, who is Professor of Pulmonary Medicine and Director of the Department of Pulmonary Infectious Disease at Hannover University in Germany. He is the past president of European Respiratory Society, and I have to say he is one of the persons with the broadest experience in respiratory infections, going from nasal congestion up to ICU infections and lung transplantation. So please, Dr. Tobias.
It's a pleasure for me to give you an overview what happens with COVID-19 pandemia in Europe and mainly in my home country in Germany. And I want to give you some insights into epidemiology, diagnostics, and treatment of COVID from a European perspective. These are my conflicts of interest. These are the actual data of the prevalence of COVID and the number of deaths in Europe. And as you can see, Spain and Italy are mostly affected with more than 150,000 patients ill from corona SARS-2 virus and a huge number of deaths. So more than 19,000 in Italy and more than 16,000 in Spain directly related to COVID-19. Germany is number 3 with more than 120,000 cases, but with a very low mortality of a little bit more than 2,600 cases. And then France and the United Kingdom are the next in the ranking. It's to mention that the United Kingdom has started with corona pandemic at a very late time point, and the numbers in the UK are rising day for day much more than in the other countries I mentioned, and we expect that United Kingdom will overcome the other countries which are on a downslope with regard to COVID-19 disease. These again are the actual numbers in Germany, and as I said, you can see we had an increase in numbers until the weekend 2 weeks ago, and now we have a slight but recognizable decrease of patients' numbers, and today we are at the lowest new case recognition since 3 weeks. Coming back to how COVID started and were recognized. The first patient known was diagnosed in Wuhan in China on the 8th of December. Up to now, we think that this was not the first case, but there had been cases minimally a month ago, but not diagnosed. China did not report the first cases of COVID-19 for about a month. They did not speak about it, and it was obvious in the beginning of January when the numbers increased by far like an explosion, and there had been a huge number of cases in Wuhan. Wuhan seems to be the center of the first China outbreak, and because of this rapid increase of cases, the hospital system in Wuhan was overloaded, and for some days there had been a breakdown of hospital resources in Wuhan. The first case in Germany was reported beginning of January 2020, and this was in a company in the near Munich, and the story was that someone from Wuhan in China came to this company for educational reasons, and it's quite clear that this woman had been ill. She suffers from cough and fever when entering the Munich company, and today we know both parents of this young lady also had been ill with COVID-19. This young lady infected two of the co-workers of the Munich company, and later on, in between the next days, 12 of the co-workers were positive for corona SARS-2 virus, and some of the co-workers infected other people in the household, 2 kids and 2 of the wives. All these patients had been isolated in the infectious disease unit at Munich State Hospital, and none of them had been severely ill. After 2 weeks of isolation, they were negative for corona SARS-2 virus and returned to home. And besides these people, nobody was infected at this time point in the Munich area. Here are some of the key features of the Chinese patients. This is a Wuhan paper published a month ago. And if you look to the data we have from Europe, from the US, from Asia, the features are the same worldwide. So most of the patients are old, 60 years or older. Most of the disease is mild. About 80 to 85% suffer from mild disease without hospital admittance. 10 to 15% are severe, and severe means with the feeling of dyspnea and oxygen desaturation, and about 5% are in respiratory failure, so need intensive care treatment, and most of them need mechanical ventilation. So mortality is high in the elderly. As older you are, as higher the burden of death is, and this is the second most important risk factor besides age, comorbidities. So first and most important comorbidity is cardiovascular, hypertension, but also left heart failure or other chronic heart diseases. And the second most important risk factor is metabolic syndrome, mainly diabetes mellitus. Very surprisingly, pulmonary disease, asthma or COPD, are not among the most important ones. There is a slight increase in COVID prevalence in lung disease patients, but it's not as high as it is for cardiovascular disease or diabetes mellitus. The reason may be that corona 2 first attacks the pulmonary endothelium, and the first symptom of corona disease is a breakdown of the endothelial barrier and a leakage of water and plasma into the lung, an increase in extravascular water. And this is different from influenza disease, where the first pathophysiological side is the alveolitis, and it's very logical that in alveolitis cases, patients with chronic lung disease have a higher risk, whereas in on the endothelial side, cardiovascular disease plays a higher role. One of the specificities of corona 2 SARS virus is that between infection and first symptoms, there is a long time delay. So from infection to first symptoms, it's in mean 5 days, and it can be 10 days. And from first symptoms to severe disease to intensive care admittance, it's another 7 days. This means from infection to severe disease, it could be 2 to 3 weeks. This is one of the reasons why the prevalence numbers reported and the number of deaths reported are different in different time schedules, because patients who are newly diagnosed are severely ill weeks later, and so the burden of death is higher with a 2-week time delay. And this time delay makes a number of problems with regard to diagnostics, and I will show this in the next slides when we talk about diagnostics. Normally we use PCR technology and we use nasal or throat swab. I'm not in favor of throat swab, because if you take the specimen, you induce cough, and cough means there is aerosol production, and aerosol production is a risk for the infection of the staff, so we want to avoid it, and therefore we prefer nasal swab. However, if patients are in the beginning of the disease, in between the first 4 to 5 days, because they are infected, they are negative, they are positively tested after the first symptoms occur, and in the more severely ill patients, when the virus is no more in the upper airway but has moved to the lower airway, the upper airway diagnostics also could be negative. And this has been shown in this paper published recently in CID. Patients with clear symptoms had been negative in PCR technology. They had a typical CT. I will show you this later on for COVID-19 disease, and then they got a lower airway specimen, tracheal aspiration, and they were positive. So in the early phase of COVID disease, diagnostic is negative, and in the more severe cases, when lower airway disease is predominating, the nasal swab also can be negative. These are the CT features, and as you can see, this is a very typical picture with pleural consolidations on both sides. There is nothing to be seen in the central airways. And if you see this picture, which looks more like an autoimmune disease than an infectious disease, it's more or less pathognomonic for COVID-19. So when we are unsure whether the test, the diagnostic test, the PCR test is positive, we normally perform a CT scan to confirm the diagnosis. The third discussion point is antibody testing. However, this is not standardized at the moment. There's no antibody test available on the market which is specific. There are two major problems. The first one is there is a cross-reaction of other coronaviruses, corona 1, 2, 3 viruses, which are responsible for rhinitis in the autumn and winter time, but never cause a severe disease. This is very often in children and kindergarten children and in pupils, and the antibody tests available do not distinguish between the non-severe coronaviruses and corona SARS-2 virus. And the second problem is in most of the patients, and mainly in patients who are not so severely ill, the antibody response is very low. So you only find low antibody levels, and only in the severely ill patients, they are really high and can be used for diagnostic purposes. So using an antibody test at the moment does not confirm the COVID disease and is not of use in clinical practice. So finally, I move to treatment options. And the main feature of COVID-19 disease is respiratory failure. There is a small portion of COVID-19 patients which suffer from heart failure, about 5%, but dominant is respiratory failure. And the dominant blood gas feature is low PO2, normal PCO2, so hypoxemic respiratory failure. With this, we primarily use high flow oxygen therapy. You also can use non-invasive ventilation. We do this very seldom in my hospital because aerosol production is higher in non-invasive ventilation than in high flow oxygen, and we try to avoid aerosol production to protect our staff. If patients do not improve with high flow oxygen therapy and PO2 deteriorates, they have to be intubated and ventilated. So very surprisingly, prone position has been shown to be very effective in COVID disease. So we put the patients immediately after intubation into prone position and let them in this position for 48 hours before turning them back. If they deteriorate again in the back position, we again put them into prone position. Other than in other forms from RDS, we do not use high PEEP therapy. This has been shown to be not effective in COVID-19 disease. We use a mild to moderate PEEP, something between 8 and 10 millimeters of mercury together with the prone position. What do we know about extracorporeal membrane oxygenation? Altogether, these are data from China. About 10 to 20% of the ventilated COVID-19 patients do not improve with normal ventilation and prone position. And because of deterioration, they are put on extracorporeal membrane oxygenation on ECMO. Mortality worldwide for ECMO patients is high. In China, it had been reported that about 60 to 70% of the ECMO patients had died. It's better in the European centers. In France and Germany, we have a mortality rate for ECMO patients, which is about 30%. Finally, I want to focus on treatment options. And as you can see, this is from NIH Gov today, and it shows that there are more than 300 studies ongoing for COVID-19 and testing interventions. This is a list of some of these interventions. Most of them are drugs which are repurposed, which means these drugs have been used for other indications, and now, because of theoretical considerations, there are trials for COVID-19. Starting with hydroxychloroquine, a malaria drug, HIV drugs, antivirals, and the most popular ones is remdesivir. Interferon is used, and a number of anti-inflammatory drugs. And from a theoretical point of view, the maybe most successful one is anti-IL-6. However, there are only a few randomized controlled trials published, and this is one of the major problems during the COVID pandemic, because patients because patients are severely ill. A lot of drugs had been used in a non-randomized fashion, and these are the first data from Wuhan demonstrating that antivirals had been used in more than 90% of the patients, antibiotics in all patients, corticosteroids in close to 50% of the patients. These polypragmasia makes it very difficult to evaluate what has been successful, and I strongly recommend only to do and to be part of randomized controlled trials in the future. Here, the first data for an HIV drug, lopinavir, ritonavir. This is a randomized controlled trial from China, and altogether there had been no efficiency demonstrated in this study, and I would not use this drug anymore in future. These are data from a French trial about hydroxychloroquine, and after this trial showed a faster reduction of viral load in the airways without demonstrating better outcome parameters. The American president ordered a huge amount of hydroxychloroquine for COVID-19 treatment. At the moment, we are waiting for randomized controlled trials, which are run in different networks, and I think this drug cannot be recommended before these randomized controlled trials are finished and analyzed. Either with the HIV drugs and with hydroxychloroquine, these drugs have a lot of side effects, cardiac side effects, liver side effects. Hydroxychloroquine is a drug with a lot of interactions with any other medication, and though there are harmful effects by using these drugs, and therefore you need to show the benefit very carefully. The third drug which is in discussion is remdesivir. Remdesivir is an antiviral, and the first data from a compassionate use program, so an observational study, had been published in the New England Journal 10 days ago. Small number of patients, altogether 53, no control group, and it looks like that using remdesivir there is an improvement in COVID patients, not only in those who are mild or moderately ill, but also in the severely ill patients. However, in Germany, we did not use any drug for a long time, and even without any medication, we had an improvement of the patients, which is comparable to what is shown here. And again, I strongly recommend only to use these drugs as part of randomized controlled trials. One of the major issues in Corona SARS-2 and COVID-19 disease is prevention. And there are a lot of discussions what the best protective measure is, which kind of face mask and what do you need to wear in addition. And there is a huge debate whether the classical mouth-nose mask, which is a so-called FFP1 mask, is sufficient, or you need more expensive and more sophisticated masks like FFP2 and FFP3. A study had been published not for COVID, but for influenza some weeks ago in JAMA, comparing the preventive effect of FFP1 in comparison to N95, which is a FFP2 mask, and very surprisingly, no difference between the mask systems had been shown. What are we doing in Germany? Well, we use regularly FFP1 masks for some more intensive interventions, intubation, bronchoscopy, endoscopy, in ear, nose, throat medicine, and at the dentist, we use FFP2 masks because there is a lot of aerosol production. And we use a so-called double mask system in the hospital, which means even the staff and the patient is wearing a FFP1 mask. And with this, we reduced in my hospital the number of nosocomial infections by far. So with this, I want to finish. This is a picture from William Turner in London about the pest pandemic in the 19th century. And you have to be aware that this pandemic, about 90% of the population died, and the dead were buried outside, burned outside the cities. So the mortality rate is high with COVID-19, but it's far away from what we had seen with other pandemics in the past. Thank you very much for your attention.
So one of the questions we selected from the audience is for Dr. Welte, and it is, what's the role of steroids in the management of patients with respiratory failure due to COVID-19?
Value of corticosteroids in COVID-19 disease, I would say this is a Nobel Prize question. Steroids had been used in China and Italy in most of the patients, and the rationale behind was that you can drop down the hyperinflammation, which is a part of the COVID-19 disease. On the other hand side, corticosteroids are very broad immunosuppressors, and they affect the immune system on different sides, though there is a high risk of being harmful instead of being efficient. No randomized controlled trial had been shown until now that steroid treatment is of benefit. And I am a little bit someone who is concerned about steroids. We do not know it we do not use it in Germany. However, if randomized controlled trials are on start, I would be impressed to see the data, but we do not use it.
Dr. Belte, we have a second question for you from the audience. The incidence and case fatality rates seem to be significantly different across the nations and higher in developed countries. What could be possible explanations for this trend in your opinion?
I can give you 3 possible explanations. Nothing of this is really proven. First, the mortality rate depends on the number of diagnostic tests which had been done in the country. Because in the patients who are more severely ill, more or less everybody is tested, but patients who are only suffering from mild disease, they are very often not tested. So if the test capacity, the diagnostic capacity is low, the mortality rate seems to be higher. We expect that due to a better organized healthcare system, the diagnostic test frequency had been much higher in the German-spoken countries, and therefore the mortality rate seems to be lower, but this is more an artificial picture. The second explanation is that in Italy and in Spain, for a long time, COVID-19 was not diagnosed or underdiagnosed. So when the majority of the patients, and as I said, the more severe courses occur 2 to 3 weeks after infection, when the majority of the patients was admitted to the hospital, the disease itself was not recognized. And this leads to a breakdown of the healthcare systems. In the German-spoken countries, we were better prepared. We start diagnostics much earlier, and the hospitals had a much longer time to be prepared. So we moved resources in infectious disease, but also in intensive care to COVID treatment. We dropped down the elective operation program, the elective surgery program, and therefore we had much more resources for COVID treatment in Germany than, for example, in Italy and Spain. And in addition, during the last 10 years, due to the economic crisis, the number of intensive care beds and hospital beds had been dropped down in Italy, in Spain, in the United Kingdom, and is much lower than in Switzerland, Austria, in Germany. So Germany has more than double of intensive care beds per population than the other countries. And also in the US, the number of intensive care beds per population is by far lower than in Germany. So for this crisis, where more resources are necessary, the German-spoken countries had been better prepared in terms of resources. The last reason is a social one. In Italy, in Spain, the number of people living together in a household is higher than in Germany. Single households, one-people households, are 6 times more in Germany than in Italy. Close contact to people is one of the main factors for virus spread. And because of this different social structure in the German-spoken countries, the risk for viral spread and viral transmission is lower in these countries. So it's a mix of explanations which made Germany better prepared for COVID in comparison to the other European countries and in comparison to the United States.
Thank you very much. And on behalf of all participants, the ATS and ERS, I would like to thank all of our presenters for their perspectives, recommendations, and strategies. A quick reminder to our participants, please complete the evaluation so we can identify future topics and continue to improve this series. I invite all participants to join us for future presentations of this webinar series, and I wish you all health and safety during this COVID-19 pandemic. Thank you all.